let's make a start. So I hope you can all hear me. I hope you're all doing well. Just finished term, I think, Christmas term, so you've broken up for Christmas. Holidays, everything, that's all lovely and good. So welcome to this talk on the cardiovascular system. My name is Amelia Fraser-Dale, you can see it there. I'm a second year medic at St. George's University in London, and the founder of Pre-Med Success, so I'm the one who's been sending all those emails. If you have any questions as we're going along, obviously feel free to pop them in the chat or email me, my email is there. Or you can head over to our website and get in touch via the contact us page, and I can answer any questions that you have on this stuff. So, there we go. This is just a quick overview of what we're going to be looking at today in the next hour or so. The anatomy of the heart, including the arteries and veins, the chambers and the valves, which are things I think you have to know for A-level. The normal function, we'll have a look at some imaging. We'll go over Starling's law, which is one of the laws that governs the action of the heart. A little bit of maths, although thankfully we won't actually be doing any maths. And then we'll have a look at pathologies, which is kind of the purpose of being a doctor, to understand pathologies and sort of know what to do about them. Okay, so the heart is a four-chambered muscular organ, and you've probably seen at GCSE and A-level being split into a so-called right and left side. I think I've got, yeah, there you go, a right and left side. And whilst developmentally this is a useful concept to have, because the heart does start with a right and left side, it's not quite as simple as that right and left split. So with any muscle, the more it's used, the more it grows effectively. If you go to the gym and work out your arms, they're going to get massive. And then if you don't work out your legs, they're going to stick thin. And the same thing kind of happens with the heart. And I'm sure you're aware that whilst the right side of the heart pumps blood just around the lungs, the left side has to pump it all the way around the rest of the body. So it has a much harder job to do. So the left side of the heart, it's being worked out more. It's going to hypertrophy, is the technical term that we would use. So the muscle is going to grow effectively in response to the fact that it has more work to do. And so the heart is going to twist sort of as you grow. The heart starts with this nice right-left split, and it's going to twist. And the left side, which is going to grow obviously more and have a much thicker wall, is going to pull the heart over to the left, kind of twist it round, so that the right side is actually more anterior, so on the front, and the left side ends up being more posterior on the back as the heart is pulled over to the left. And then the apex of the heart points down to the region just under the left breast. And if you palpate on yourself, so palpate, technical word for feel, if you have a feel and you go to the fifth intercostal space on the midclavicular line, so the space between your fifth and sixth ribs, and the midclavicular line is the middle of the clavicle, so sort of halfway between your neck and your shoulder. And you palpate just down there, and you should be able to feel on yourself the apex beat of your heart, which is the most reliable beat to feel for if you're sort of in practice, in clinical practice, if you're trying to discern someone's heartbeat. That's the best place to feel. Obviously, you can take pulses from various points in the cardiovascular system, such as the wrists and the ankles, but that's not a beat so much, that's a pulse, and there are some technical differences. When you feel the apex beat there on the fifth intercostal space midclavicular line, you're actually feeling the action of the heart, so it's quite a reliable one. And then, of course, as you're probably aware, we split the heart into a top and a bottom. We have the atria and the ventricles, and I'm sure that's not news to you and you've seen that before. And the atria receive the blood and pump it into the ventricles, and then the ventricles are kind of like the big piston-like chambers that pump the blood up into the either the pulmonary artery or the aorta. So this is quite a nice 3D model of the heart as it sits in the chest, and you'll notice first that it's protected anteriorly by the sternum, which you can feel in yourself. It's that hard, bony breastplate, effectively. there, if you can see my mouse, it's this bone here in the middle. And the sternum is a fused bone, much like your skull is fused from many plates. The sternum is also fused from three parts. We have the manubrium at the top, the body in the middle, and the xiphoid process here at the bottom. And just as a note, process, basically it means sticky out bit. So if you imagine a nerve, and we had a talk yesterday on the neurons, where you have the cell body and the axon coming out, and it was that long axon that carried the signal, that is effectively a cellular process. It's just a sticky out bit. Okie dokie. You'll also notice that running sort of parallel down either side of this sternum, we have the internal thoracic arteries and veins, just here on either side. And these are kind of the endpoint connections for your intercostal arteries, which you can see here running between the ribs. And you will have heard, I think, of the intercostal muscles. They're involved in expanding and compressing the rib cage for breathing. And so the naming is very similar. You have intercostal muscles, you have intercostal arteries, you have intercostal veins. There's also an intercostal nerve to control the muscles. And so if we strip the sternum away, if you strip the sternum away, you can see the main arteries and veins. And the veins, obviously you can see the veins here because they are more anterior. The names aren't particularly important, but the main thing to appreciate is that the upper limbs, the head and the neck, drain into the superior vena cava here, whilst the lower limbs and the abdomen and the torso and such drain into the inferior vena cava, which brings blood up to the heart. So the top drains through the superior vena cava and the bottom through the inferior vena cava. There are some vessels that you may have already heard of. So the jugular veins up here at the top, we have 4 jugular veins. The internal jugular veins here are much bigger, and they drain blood from the brain, whilst the external jugular veins, which are smaller here on sort of the, well, they're more lateral, they're more towards the outside, they are external. They drain blood from the extracranial tissues. So that's anything outside of the skull, so muscles of the face, of the tongue, of the neck, your scalp. There's actually quite a lot of stuff going on in your head that's outside of your skull. It's not just your brain. And so that's what the external jugular veins are draining. It's also important to note how, for the most part at least, the veins sit anterior to the arteries. And that is important to know. For example, in clinical practice, when you're fitting a subclavian central line, it will go, so subclavian beneath the clavicle, this is the clavicle here, which you can probably feel in yourself. So a subclavian, we're going below the clavicle, central line. And if you insert a needle below the clavicle, you're going to hit the vein first rather than the artery. So this is a good place to go if you want to insert a line into the vein, but not if you want to go into the artery, because there's no way of getting to the artery without going through the vein first. So knowing when the veins are in front and when the arteries are in front is quite an important thing. If you follow this down into the arm, you'll notice that the brachial artery here becomes more anterior than the vein. So this would be a good place to take arterial bloods. If we remove the venous system, there we go, you should be able to see the main arteries below. And again, the names of the arteries aren't enormously important, at least at this stage, but you'll notice that this is the aorta here, this big one coming out of the heart, coming out of the left side of the heart, which, remember, is more posterior, behind. So this is the aorta. We'd refer to this bit as the arch of the aorta because it arches over the heart to pass posteriorly behind it, down through the diaphragm, the level of the 12th thoracic vertebra, and out here into the sort of abdomen region here at the bottom. You can see the abdominal aorta. So it comes up, it arches over the heart, goes behind it, passes through the diaphragm at T12 and carries on down. And as the arch of the aorta arches over the heart, it gives off 3 branches. You can see 1, 2, 3. You can just see them there. It's a little bit difficult. From this view, it's easier to see them from the side. But on the right side, so over here, we have the Brachiocephalic Trunk. This is the Brachiocephalic Trunk artery, and this bifurcates. Bifurcates means splits. So this splits into the right common carotid and the right subclavian artery. And then on the left side of the body, there is no brachiocephalic trunk. So we just have the left common carotid coming straight off the arch of the aorta, and the left subclavian coming straight off the arch of the aorta. So the three branches that the arch gives off are the right brachiocephalic trunk, which then splits, the left common carotid artery, and the left subclavian artery. So there's no brachiocephalic trunk on the left side. And the sharp ones amongst you will probably have also thought, what about the coronary arteries, which are, of course, the arteries here that supply, well, you can't see them here, but they supply the heart itself with muscle, they supply the heart muscle itself with blood. And these also come off the aorta, but not the arch part so much as right here down at the base. And we'll have a closer look at those in a bit. Also, an interesting thing to note about the cardiovascular system is that when we were naming it, or in the past when people were naming it, they were very indecisive. So you'll notice that, where's my pointer here? You'll notice that this left subclavian artery, if you follow it down, it's continuous. It just changes name and it becomes the axillary artery. And then again, it changes name and becomes the brachial artery. And eventually down here, it will become the radial and the ulnar arteries after the radial and ulnar bones in the forearm. So when people talk about the subclavian, the axillary, the brachial arteries, and again, with the veins, the subclavian, the axillary, and the brachial, they're talking more about where it is in the arm. They are effectively the same artery. It's continuous. It's just, it changes name depending on where it is. So, oh, and again, you'll see that the heart is resting on the diaphragm and pointing over here, the apex being in the sort of left pectoral region here below the left breast. And so if we remove the ribs, the intercostal arteries and veins, and then the rest of this arterial system, we can expose the heart resting here on the diaphragm here towards the left. And you'll notice that the heart here is sitting in a pericardial sac. Peri from the Greek meaning next to, as in perimeter, and cardium obviously meaning heart, like a cardiac arrest. You think it's to do with the heart. So the pericardium literally means next to the heart. And this is a sac of tissue, of connective tissue, a sort of like a membrane that surrounds the heart, and it contains a little bit of fluid, and it just lubricates the heart and reduces any friction so it can beat freely, effectively, without rubbing on the other organs, for example, the diaphragm here below and the lungs on either side. The purpose of the pericardium is effectively protection and lubrication. You'll also notice here the phrenic nerves, the right and left phrenic nerves. The right one here is on the left of your screen and the left is on the right of your screen. And this is because we always talk about it from the patient's perspective. So if you imagine yourself, we're viewing them from the front. So you have to sort of flip yourself around to imagine yourself in their shoes. And so this is their right side and this is their left. And the left phrenic nerve here, it passes over the pericardium and it receives sensation from it and it innervates the pericardium. And that is partly why when someone has a heart attack and there's heart pain, it radiates to the left side and down their left arm. And it's because it's all this left phrenic nerve, left side nerves that are involved in this. Whereas the right phrenic nerve just passes behind the pericardium and doesn't really innervate it or integrate with it in any way. So the right is less involved, the left goes over it and is involved. And both of these nerves, phrenic is to do with breathing, and they go down to the diaphragm, and they're what cause the diaphragm to contract when you breathe. So if we remove the phrenic nerves and the pericardium and take a closer look at the chambers of the heart, you can see here the right atrium and the right ventricle lying more anteriorly because the heart's twisted, whilst the left atrium and the left ventricle we can't really see because they're on the back, they are more posterior. We've already spoken about the arch of the aorta coming out here and the pulmonary trunk which comes out of the right ventricle here at the front. So it's a slightly confusing 3D structure to get your head around, because we say right and left and it's actually more front and back, and then you can see how the arteries loop around each other. So hopefully we'll take a closer look at that, and we'll have, I think I've got some pictures from the side, and it should start to make a bit more sense. So now if we take a closer look at the heart, we can see that it's covered in this protective layer of cushioning cardiac fat. And then if we remove this cardiac fat, there we go, we can expose the underlying coronary arteries and veins, which I'm sure you're familiar with. And their purpose is to supply the heart muscle itself with oxygenated blood, because the myocardium, the muscle of the heart, is very metabolically active, and it can only really do aerobic respiration. It relies on lipids and aerobic breakdown. So it needs a very sort of rich blood supply because it has a very, very high oxygen demand. Okay. So I produced this flow diagram, which shows the path of the blood through the heart, both sides of the heart. Now it looks like an awful lot of info here, but don't worry, we're going to go through this step by step. And it's not that difficult once you've got a mental picture of the basic anatomy, which is why we had to look at that first. So if we start with the deoxygenated blood, and you'll notice that from the upper body, the head, the upper limbs, we're draining into the superior vena cava, whilst from the lower body and the lower limbs, we're going to the inferior vena cava. And I'm sure you remember that from just a couple of moments ago. And the important point to remember here is that the SVC and the IVC don't merge. They enter, as I've indicated here, or tried to with my arrows, they enter the right atrium of the heart separately from the top and the bottom respectively, without without merging in any way. So just to give you a quick look at that, this is the heart in the anterior view as before. So we're looking at it from the front, and we can see the superior vena cava here and the inferior vena cava here. So this is blood from the top half of the body effectively, the head, the upper limbs, the brain. And this is blood in the inferior vena cava from the lower limbs, the abdomen, your gut, things like that. And if we rotate the heart, you can appreciate now how the superior and inferior vena cavae enter the right atrium separately from the top and the bottom. So they don't merge and enter as one. They enter from the top and bottom separately, which is an important point to note. Okay, so there they are entering the right atrium. And from the right atrium, blood then flows through the tricuspid valve. Tricuspid, meaning 3 cusps. And we'll have a look at that in a second, the structure of the valve. And it flows from the right atrium through the tricuspid valve into the right ventricle. And I'm sure you will have heard these, the chambers before, you'll be quite familiar with these. So here's the heart, again in the anterior view. And the blood is going to flow from the right atrium here down into the right ventricle here. And the purpose of the tricuspid valve between these is to prevent backflow when the right ventricle contracts, because we wanted to push blood into the pulmonary trunk here, not back into the right atrium, otherwise blood's going the wrong way. So that's why we have the valve. And if we take an imaginary cut through the heart, so about here, we're going to cut off the atria and the pulmonary trunk and the arch of the aorta and all of that, and look down from the top onto the ventricles, like this. Here you go. So here's the right atrium and the right ventricle. Here's the left atrium here. They're grayed out so we can see the valves. And you'll notice when I said that the left side of the heart is on the back, notice how the left atrium goes all the way across the back of the heart. And then here's the left ventricle sort of beneath it, also on the back. And here we can see the valves. And the one we're concerned about, right atrium to right ventricle, it's the tricuspid valve. And I hope you can appreciate from this picture, although it's not quite head on, that there are 3 cusps to this valve. And the slits between them, it's sort of like a Mercedes badge. And when the blood flows through, these will obviously open to allow the blood in. And then when the right ventricle contracts, it's going to push back against the valve, but it doesn't open the other way, so it's going to close and not let any blood through. Whilst we're here, I suppose we can also point out the aortic valve, which goes into the aorta, the pulmonary valve, which goes from the right ventricle into the pulmonary trunk, and the mitral valve, which goes from the left atrium into the left ventricle. And notice here how the tricuspid and mitral valves point downwards, whereas the aortic valve and the pulmonary valve point upwards. And this is because the blood is flowing in opposite directions through these valves. So from the right atrium to the right ventricle, the blood is going down. And similarly from the left atrium to the left ventricle, the blood is going down. Whereas out of the ventricles going into the aorta or the pulmonary trunk, respectively, the blood's being pumped back up. So it sort of changes direction. And that's why these valves, you're looking at the underside of the valve here. It's the other way around. So the aortic and pulmonary valves would open to allow blood to come up. Okay, back to our flow diagram. We've done right atrium through tricuspid valve to right ventricle. And then, of course, we go through the pulmonary valve, which we just had quite a quick look at, into the pulmonary trunk. And so here we go. This is a similar view to before, but instead of having the atria on here grayed out, I've got the arch of the aorta and the pulmonary trunk grayed out. And again, so this is the right ventricle here on the front. This is the left ventricle here on the back. We're concerned with the right one. And it's received blood from the right atrium through the tricuspid. And it's going to pump blood back up through the pulmonary valve into the pulmonary trunk. And note how the pulmonary trunk is T-shaped, so T for trunk. Kind of makes sense. So it bifurcates into a right and left side. Bifurcate, remember, just means split. So it splits into right and left. And each right and left goes to the right and the left lungs, respectively. So the right lung is over here, and the left lung is over here. And so here it is, sort of from a front view, you can see how the pulmonary trunk comes up, T for trunk, and it splits into a right branch, a right pulmonary artery, and a left pulmonary artery, like that. And the right branch, you'll notice, goes under the arch of the aorta, so the aorta kind of loops over it. So now the blood's got its way to the lungs, where obviously it's going to be oxygenated. And the lungs are a whole different topic that we might be able to do a talk on in the future, slightly beyond the scope of this. Whoops, sorry, I've temporarily lost my place. My screen's got, there, okay, we're back. Sorry about that. So the blood's here in the right and left lungs. It's becoming oxygenated, and it's going to flow back to the heart through the 4 pulmonary veins. Pulmonary just means to do with the lungs. So we have the pulmonary trunk, the pulmonary arteries. Now we have the pulmonary veins. It's all to do with the lungs. There we go. Okay. Here you go. You can see the 4 pulmonary veins on the back of the heart, 2 from the left lung and 2 from the right lung. Don't ask me why there are 2 from each lung. That's just anatomy being strange. There might be an evolutionary reason. I honestly don't know. But again, we can point out the relevant structures. So this is the left atrium going all the way across the back of the heart, if you remember. And then this is the left ventricle here at the bottom. Remember, left is more posterior. And then the left ventricle is going to pump its blood up into the arch of the aorta, which loops over the top of the heart, arches over, giving off 3 branches, which you can see here. This view is quite good actually for showing the branches, and then passes posteriorly behind the heart. So here we go. This is the top view again. And you'll notice this left atrium here. Here are the pulmonary veins, here and here. And you'll notice how the left atrium passes all the way across the back of the heart, so it can receive blood from both the right and the left lungs via the pulmonary veins, because it covers the entire back of the heart here, or the entire back of the top of the heart, I should say. And then the right atrium pumps its blood down through the mitral valve, otherwise known as the bicuspid. You might have heard that term. A mitre is, I think, a bishop's hat, if you imagine that kind of strangely curved, pointy hat thing. Bicuspid also makes sense because, like the tricuspid, which had 3 cusps, the mitral or bicuspid has 2 cusps. And the way I remember this is because 2 cusps, so bicuspid or mitral valve, there are only 2 things to go wrong, effectively. Whereas the tricuspid, there are 3 cusps, so there are 3 things to go wrong. And so the mitral valve, with only having 2 cusps, it's slightly more reliable and able to withstand higher pressures. It's a stronger valve because it only has 2 cusps to worry about. And they're 2 really big, chunky cusps as well. And that kind of makes sense because the left side of the heart, as I'm sure you are aware, it pumps blood all the way around the body and it has much higher pressures than the pulmonary circulation, so the right side of the heart. So the mitral valve has to be stronger to withstand the higher pressures, which is why presumably it only has 2 cusps and is therefore sort of reinforced. It's much stronger. So moving back to our diagram, we've got the left atrium pumping blood through the mitral valve into the left ventricle, and then the left ventricle pumps its blood through the aortic valve into the aorta, which makes sense. If we have a look at the aorta here, so this is our top view, here's the arch of the aorta going over the top of the pulmonary trunk, which is shown here in grey, and here's the aortic valve, so named because it pumps blood into the aorta. It does make sense. And this, again, this has 3 cusps, and it's coming from behind, from the left ventricle here at the back. And then the aorta arches over the pulmonary trunk. I know I've said it loads, but hopefully that will get it ingrained in your minds. It arches over the pulmonary trunk and passes posteriorly down the back of the heart. And we have, there's the picture of it coming over the heart and going down the back. And there are 3 branches, which we spoke about earlier. So at this point, to keep it interesting, I have a quick question. I'm going to see if I can use the polling function and see if you remember what the 3 branches of the aortic arch are. So hopefully you will have received that. And don't worry, the answers are all anonymized, so I can't see who said what. Let's see if you can give that a go, see if you can remember. And there we go, we've got a couple of votes coming in now. Just give you a moment to think about that. Oh, there we go, a lot more people. Awesome. Okay, it looks like almost everyone. Oh, there's 1 person left. You know who you are. Guess. I'll give you a hint. There was no such thing as the left brachiocephalic trunk. So I'm going to end this now. There we go. And I think you can probably see the results. They are anonymized, obviously, but you can see the results. And so let's just talk through this quickly. I won't flick all the way back to the slide, but you remember that there was only a right brachiocephalic trunk, because on the left side, the left common carotid and the left subclavian came directly off. And these are quite popular answers here. left common carotid, and left subclavian. So yes, those are definitely correct. And then the right common carotid artery, the right brachiocephalic trunk, which then splits into the right common carotid and the right subclavian. So those don't arise directly from the arch. There is no such thing as the left brachiocephalic trunk, because the left common carotid and the left subclavian come directly off the arch. And the right and left internal jugulars, which were the options down there at the bottom, are veins. So they're not going to come off the arch of the aorta, which is an artery. So this, by the way, is a similar style of question to what you'd actually have in sort of medical school exams. They tend to do questions by multiple choice in this style, simply because it's easy for a computer to quickly mark them. So that's a sort of what it's like doing an exam at med school, although of course that was only one question. Okay, moving on, hopefully, to imaging. So actually, I'm going to launch straight into a second poll here. We're going to look at what types of imaging do you think allow us to see the heart? And before I launch this, or actually I'll just bring it up. There we go. There are a couple of options here. So MRI, CT, X-ray, and ultrasound. And when you're answering, just consider the fact that the heart is soft tissue. And hopefully that should help with your reasoning. There we go. I can see a couple of votes coming in. Nice. There are lots of people. Brilliant. Again, the results are anonymized, so. Two more people. Guess. Doesn't hurt to guess. Okay, I'm going to, oh, there we go. Perfect. There we go. Okay, I'm going to end the poll now. And hopefully post the results. And the overwhelming majority of you said MRI, which is, yes, definitely true. The MRIs are brilliant at imaging soft tissues like the heart. Remember, the heart is a muscular organ. It's made of muscle. There's nothing really solid in it. There are no bones of the heart. There's not any cartilage of the heart. I suppose the stiffest thing in there is parts of the valves, which are connective tissue effectively. So it's mostly soft tissue, or entirely soft tissue, and MRI is brilliant at soft tissue. So yes. A lot of people voted for CT, and now you see CT is a type of X-ray, and X-rays are brilliant at viewing hard things, or things that retain electromagnetic waves well. It's to do with attenuation coefficients, which you might have come across if you're doing physics A-level. So X-rays are good at viewing hard things like the bone, and obviously there are no bones of the heart. So good to see no one put X-ray, because yeah, you can't see the heart very well on an X-ray, and I've got an example of that in a minute. But a CT, as I'm sure you're aware, is many, many, many X-rays taken from many different angles and then sort of compiled together by a computer. And there's a much higher radiation dose here, which means it does have a slightly improved ability to view soft tissue. Still not fantastic, nothing like an MRI, but it's improved. So you could theoretically view bits of the heart on a CT, but we have a trick up our sleeves, which is a CT angiogram, which we'll get onto in a minute, where you use a dye, a contrast in the blood, to enable you to view it quite actually, remarkably well, actually, in a 3D model. So we'll get onto that in a second. So yes, you can, in short, see the heart on the CT. And then ultrasound. And ultrasound doesn't sound like, it's not very sophisticated. You wouldn't think, oh, ultrasound, yes, you can look at the heart, but you can. And most people forget about it. So well done, those of you who got that one. Okay, so Oh, whoops. There we go. Okay, so the cardiac MRI, we've already spoken about. Yes, definitely. A normal CT, not so much, but a CT angiogram, yes. And the CT angiogram, effectively, you give a contrast medium. It's iodine normally. Iodine is quite heavy as an element, so it retains X-rays quite well, much like bone, and it effectively makes the blood show up on an X-ray or on many X-rays. A CT is many X-rays, and so it's given intravenously straight into the vein as an injection, and then we CT the heart, and it's used to image the coronary circulation. So not so much the heart muscle itself, because once the iodine has got its way into the muscle, it's kind of diffused out a bit and it's not all in one place, so we can't view it very well. But an angiogram, a CT angiogram, brilliant for viewing the coronary circulation for things like coronary heart disease, which we'll have a look at in a minute. I think I've got one of those to look at. And then finally, an echocardiogram, which is a type of ultrasound. Again, I've got an example of this, and they are really good at viewing the heart in a sort of quick and easy way. And finally, an X-ray, just a normal plain film X-ray, good for dense tissue such as bone, but not soft tissue like the heart muscle. You can't see detail, and I've got an example of what no detail looks like in a second. So this is a cardiac MRI. Now this looks phenomenal. This is because this isn't in a person. This is a specimen, a heart specimen that's been taken out, prepared effectively on slides, and then MRI'd. So this isn't in a person, which is why you can't see any other organs around it. But it really shows you sort of the level of detail you can get out of an MRI. You can see the valve cusps here, this either the aortic or probably the pulmonary, actually, the pulmonary valve here, the aortic valve here. This much thicker walled chamber would be the left ventricle, the right ventricle being much thinner because it doesn't have so far to pump the blood. And you can see the incredible amount of detail that you're able to see on a cardiac MRI. So you've seen, I've said specimen in a T1 weighted MRI. Broadly speaking, there are several different types of MRI, but broadly speaking, we have T1 and T2. And I won't go into the physics of how an MRI machine works, but it's to do with your MRI machine is sensitive to different wavelengths of normally microwave. And by slightly changing the calibration, you can get it to look at fat or water, respectively. So a T1 weighted MRI, such as this, looks at kind of fats and, fats, effectively, and they show up bright. So fat and muscle, you can see here, showing up bright, whilst the water is showing up dark. The water is effectively the blood. The blood is just, or for the most part, the blood is water. Whereas on a T2 weighted MRI, and I don't have a picture of, neither of these are T2, these are both T1, so I don't have an example of this to show you, but on a T2 MRI, the colors would effectively be inverted. So a T2 looks for water. Think H2O. It's a T2 MRI, H2O. That's how I remember it. And so watery things show up bright. So the blood here would be bright and the walls of the heart would be kind of dark. And they have different uses. Obviously, the T1 is really good here for viewing the heart. A T2 would be used if you were looking for water, for example, if there was internal bleeding, because the blood is effectively water. And so they have different uses. This is a T1 weighted MRI. T1 because the water is dark and the walls of the heart here are light. And this is actually in a patient. So this is a cardiac MRI of a patient, and this shows hypertrophy. This heart is much bigger than it ought to be. And it also looks like the heart's on the right-hand side, which is kind of weird. It's not, this is normal. You have to remember that an MRI is as if you were looking up at the person. So like you're lying between their feet, looking up at them, effectively. We're looking from the underside of this slice of imaging. So the left side is actually over here. You can just see the left arm at the edge of the image, and the right side of the person is over here. So just like everything with medicine, it's completely backwards. And whilst you would expect the apex beat of the heart to be sort of here on the front, it has moved, as I'm sure you can see, round here, sort of into the axilla, round under the armpit. And this heart is much bigger than it ought to be. Okay, now an echocardiogram, it doesn't look like much. It's a bit overwhelming, a bit fuzzy, and I will admit, at second year in my medical degree, I have not had a chance to really get to grips with these and learn how to interpret them very well. So I'm relying on this labeled image, courtesy of Radiopedia, which is a brilliant resource if any of you want to look up things. So here you go, left ventricle, right atrium, left atrium, mitral valve, tricuspid valve, they're all labeled there. But the way an echocardiogram works, or indeed any kind of ultrasound, is you have a transducer, this is the handheld bit, that sends out sound waves, effectively, ultrasound waves, so anything above 20 kilohertz, outside the range of human hearing. And it sends out the waves, and they sort of spread out. Think like if you drop something in a pond, and we'll know that because those ripples will go out in every direction. So a directional pond ripple, I suppose. If you imagine you know the Wi-Fi symbol where the waves are just going in one direction, it's a bit like that. It sends out a cone of sound waves in one direction, effectively. And so in this case, we're holding it against the chest, and we're sending the sound waves down into the heart. Down into the heart. And so it gives you a kind of cross section, because the sound waves are, the transducers here at the top of the cone, effectively. Here's the cone. And so the sound waves come down, they hit things and they bounce back, just like an echo in any normal situation. And then there are very sensitive receptors in the transducer that are able to detect these echoes from different parts of the heart, or the heart in this case, or whatever it is you happen to be imaging, and interpret them into a sort of image like this, where the whites here show lots of reflections. So there's obviously something here that's very good at reflecting, high density. And then the black is very little reflection. So this is probably something like water, and it is water because it's blood. And so they give you this kind of cross section through the heart. So the transducer's up here, and this is a cross section. It's very quick. It's incredibly easy to do. It's non-invasive. You can do it on a ward. Echocardiograms have loads of really good benefits, but as I'm sure you can see from these pictures, the image quality isn't fantastic. And that can be a problem when you're trying to diagnose little things that require sort of more high attenuation. This is a CXR, so chest X-ray, that stands for. And this is a plain film X-ray, just to show you how poor an X-ray is at imaging the heart. It's just this kind of white blob. So this is a plain film X-ray. It's not 3D like a CT scan. It's good for dense tissues such as bone, but not soft tissues. And you can see the dense tissues here, the bone, the ribs here shown up really well, and actually in quite good detail. We can be sure this person has no broken ribs. You can see the clavicle here, the head of the humerus of the arm up here, but the soft tissues, the diaphragm at the bottom here, and this blob that is the heart, it's not very good for cardiac detail and soft tissue detail. So that's the anatomy of the heart, the arteries, the veins, the valves and chambers, the normal function, and we've had a look at some imaging. And now, just quickly, we're going to look at Starling's law, one of the sort of physical laws that governs the heart. And then we'll do the fun bit, which is the pathologies. So Starling's law states that, as you can see here, the length of the muscle fiber at rest is directly proportional to the energy of contraction that can be generated by that cardiac muscle. Lot of words there. Effectively, what this means, if we break it down, is that the more stretched the heart muscle is at rest, the more forcefully it can then contract. There you go, more stretched means more force. And if you think about it, that kind of makes sense. If you think about breathing is a good analogy for this. If I asked you to just breathe out as hard as you can without taking an in-breath first. So just from resting breathing, breathe out as hard as you can. It's never going to be as strong as if I let you take a really big in-breath first to really stretch your lungs, and then you can breathe out much harder. So with exhalation, if you're able to breathe in lots and stretch out your lungs, you can then breathe out much harder. And it's the same with the heart. If you stretch the heart muscle at rest, if the chambers become really big and inflated, they can then contract with a lot more force. And that's effectively what Starling's law is saying. The length of the muscle fibers at rest, so the more stretched the walls are, the greater the force of the contraction that can be generated. And Starling's law is due to an intrinsic property of cardiac muscle. It comes from the way that sarcomeres, which are the contractile units of muscle, they're an organelle. It comes from the way that sarcomeres are sort of put together and slide over each other and have friction. So it's not to do with nerves or hormones or anything that's under your body's direct control. It's something your body has to deal with, as opposed to something that your body can manipulate. So it's due to an intrinsic property of cardiac muscle. It's outside of your body's control. And in practice, this means that the volume of blood that returns to the heart is equal to the volume that is then expulsed from the heart. So the heart can't pump out more blood than it receives, and that's impossible. And that makes sense. The more stretched you are, the more you receive, the more you can then pump out. And you can't pump out more than you've got, effectively. And this is really useful because it balances the cardiac outputs of the right and left sides. Remember, they're not connected in any way really by nerves or hormones or anything that your body can control. So this physical law, just of how cardiac muscle works, Starling's law, balances the cardiac output of the right and left sides. The left side can only pump as much blood to the body as the right side provides to it by pumping it around the lungs. You can't pump blood to the body faster than you can pump blood to the lungs. So the right and left side are balanced in their rate of blood pumping, or their volume of blood pumping, I should say. And this prevents congestive blood clotting. It prevents like a congestion of blood, a traffic jam, if you will, of blood building up in one area and not being pumped quickly enough by the other side of the heart. And if blood sort of builds up in an area and stops flowing and becomes, well, static, we refer to it as blood stasis, then it can clot, which can be very dangerous. So that's enough of that. Now we can look at the pathologies, which is, as I'm sure you are aware, the fun stuff of being a doctor, or at least in my opinion. And so the first one we're going to look at is valve problems, valve stenosis and valve incompetence. These are two conditions, I should say. Valve stenosis is one thing, and valve incompetence is another. Stenosis is when the valve becomes stiff, and incompetence is when the valve becomes leaky. And both, as it says here, both cause bruit. And bruit is the sound of turbulent blood. It's what you listen for with a stethoscope. When you auscultate, auscultate just means listen. So you auscultate and you palpate, is listen and feel. When you auscultate with your stethoscope, and you can hear a kind of slooshing noise, as opposed to the regular dump, 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 dump of the heart valves. If you hear a slooshing noise, the technical term for that is a bruit. And this can be caused by turbulent blood, so blood sloshing over itself, which is indicative of either valve incompetence or valve stenosis. So I've got here we go, a lovely GIF, or GIF, if you will, on cardiac MRI. Now, I've got some poll questions to ask on this, if I just bring them up. So the first one is just harking back to what we did on imaging. Do you think this is a T1 or a T2 weighted MRI? Look at what's bright and what's dark and think T1 or T2. We've got some votes coming in. Oh, there we go. Any more? Anyone care to guess? A couple more people. There we go. Okay, that's basically everyone now. There we go. Cool. So I'm going to end this. And there we go. And that's actually quite close. So T2 was the eventual winner. It lagged a bit at the beginning, but then sort of caught up. And you're quite right. T2 is the correct answer, because if you have a look at the heart here, what's showing up bright? It's the blood, and blood is basically water, H2O, T2 MRI. So a T2 MRI shows up water well, and the blood here is white. Whereas if you remember back to our T1 weighted MRI, the muscular walls were bright white and in exquisite detail, and that's because a T1 MRI is good at fats and muscles and all of that stuff. So this is a T2, T2 for H2O. It's showing up the water as bright. Okay, so you may have already noticed, but I'm going to point it out anyway, that when the heart beats, here you go, when the ventricle contracts here, there's blood backflow into this atrium here. So these are the atria, and these are the ventricles at the bottom. The atria are pushing blood into the ventricles, and the ventricles then pump the blood either around the lungs or around the body. And you'll notice, you can see it here as black, slightly turbulent blood flowing back into the atrium here. And so the next question I'm going to ask is, hang on a sec. There you go. Is this valve stenosis or valve incompetence? Just a couple more people. And the definitions are there on the left, if you forget. And there we go. Okay, perfect. So it's an overwhelming win here for valve incompetence, and you're quite right. The valve here is leaky. It's leaking blood back. So this is incompetence. Valve stenosis, stiffness of the valve, could also cause a little bit of backflow, but not as much as this. This is quite a lot of blood leaking back. So this is probably a damage around where the valve actually closes, I think. One of the cusps might be a bit loose, and blood is able to force its way back. So this is valve incompetence. The valve is leaky. And now, of course, the final thing that we have to work out is which valve is incompetent. So again, I have a poll. Let's there we go. Which of those four valves, the tricuspid, the mitral, the aortic, or the pulmonary, do we think is incompetent? Remembering, of course, that on an MRI, you're looking up at the person as if you were laying between their feet. So right is left and left is right. Ooh, everyone's voted on this one. Nice. I think that's the first time we've had everyone get a vote in. Brilliant. So hopefully you can see that. Mitral valve, again, is the winner. And yeah, if you have a look on the MRI here, pardon me. Firstly, if you just think about MRIs, so you're looking up at the person. So you're lying between their legs, effectively looking up. So this is their front, this is their back, this is their left, this is their right. And so this is the left side. You can also tell because it's sort of on the back of the heart, if this is the back and this is the front. This is therefore the left side, or really I should say the posterior side, but the left side of the heart. You can also tell it's the left side because the wall is much thicker in the ventricle, and it has to pump blood all the way around the body, as opposed to the right ventricle, which only has to pump it around the lungs, so much shorter distance. So that also indicates that this is the left side we're dealing with. And then the valve between the left atrium and the left ventricle is, as most of you have said, the mitral valve. So mitral, remember, or bicuspid is the other way of saying it. Two cusps, looks a bit like a bishop's mitre, that kind of weird hat. So yeah, two cusps, it's much more reliable. And that's because this side of the heart, this sort of posterior left side, has much higher pressures. And so the valve has to be more durable to sort of withstand those pressures effectively. So the tricuspid valve is this one here on the other side. This is the right side of the heart, or the anterior side of the heart. So you were close, those of you who said that, but this valve is working fine, and it's just on the other side of the heart. And then the aortic and pulmonary valves, to those of you who mentioned those, go from the right and left ventricles into the, or rather the aortic is from the left ventricle into the arch of the aorta, and the pulmonary is from the right ventricle into the pulmonary trunk. And so you can't actually see either the arch of the aorta here, really. Actually, it might be there, might be just there, passing posterior to the heart. You definitely can't see the pulmonary trunk here. This valve is between an atrium and a ventricle. So that's how you know it's either mitral or tricuspid, and then it's on the left side, so it's mitral. Perfect. So this is, putting all of that together, this is mitral valve incompetence, or left-sided valve incompetence. And you can see the backflow here. Okay, it's 6 o'clock now, so I have, oh, in fact, this is the last pathology, this is the last slide, so we're not far off. I won't keep you from your evenings much longer. So myocardial infarction, and this is something you've probably heard of loads. It tends to be a very popular one amongst sort of pre-med students and people, because heart attack, I mean, everyone's heard of heart attacks, and it's fairly commonplace, well, unfortunately. But what does an MI actually mean? And so if we break this down, myo comes from the Greek meaning muscle, and cardial, obviously, cardio meaning heart. So this is the muscle of the heart, is the first point. So myocardial is the heart muscle, as opposed to the heart valves, or the heart arteries, or the coronary circulation, or even the space inside the heart. This is specifically to do with the muscular walls. That's what myocardial means. And then infarction means cell death. So we mentioned previously that the heart is incredibly metabolically active. It needs a rich blood supply, hence the coronary circulation. It relies on oxygen, O2, and lipids. It can only break down lipids. That's sort of its fuel. Unlike the brain, for example, which can only rely on glucose, and then other tissues can, like your muscles or your skeletal muscles, moving your limbs, can use all kinds of different food, or fuel, I should say. But the heart muscle specifically is very picky. It just likes lipids. They're very energy dense, so that's what it likes. And it relies on oxygen for its aerobic respiration. So infarction is cell death due to hypoxia, so not enough oxygen. Hypoxia, hypo meaning not enough or low, and oxia meaning oxygen. And so I've just done another sort of flow diagram to clarify some key points that people might get confused. I get these confused occasionally, so it's understandable. But ischemia is, yeah, don't worry too much about reduced CO2. That's reduced total or common arterial oxygen levels due to like blocked lungs, COPD, something like that, pneumonia. But ischemia, this is reduced tissue perfusion. So both of these ones here, the way that they're grouped here vertically, these are issues with supply, either supply of oxygen to the blood or supply of blood to the tissue. Ischemia is a reduced blood supply to the tissue. So these are both problems with supply. And either of these problems will cause low oxygen levels, which is hypoxia. And eventually, if hypoxia is allowed to carry on long enough, it will cause cell death, which is infarction. So ischemia or reduced oxygen, blood oxygen. Ischemia is reduced blood supply, or reduced CO2 is reduced blood oxygen. Either of these reduced supplies cause hypoxia, low oxygen, and then hypoxia or low oxygen causes infarction or cell death. So you remember previously we mentioned CT angiograms, where you put in a dye, iodine, intravenously. You inject iodine, and then it travels through the blood and makes it effectively more dense as far as x-rays are concerned. So it shows up. And you can see here, this is the coronary circulation showing up incredibly well as a kind of 3D model. So the heart is kind of here. If you imagine these 3 coronary arteries, you can see here branching off as being sort of like fingers, almost like imagine 3 fingers in a claw grip around this slightly grayish dark area, which is the heart. Imagine like 3 fingers holding the ball at the top of a walking stick or something. So, or holding anything, I suppose, holding a ball of some description. Those of you who play cricket, imagine how you hold a cricket ball. Your 3 fingers effectively around the ball. That's effectively what's going on here. So there are the 3 coronary arteries we can see here surrounding the ball of the heart. It's not really ball shaped, but for the purpose of this image. And then this here is the arch of the aorta coming over here. Because all the blood is showing up dark because we've injected iodine, not necessarily just the bits we want to look at. So these are the coronary arteries. This one here is the left anterior descending artery, or the LAD. Again, I'm not going to go into detail of the coronary circulation. That's a whole different topic for another day. But I'm sure you can notice that just about here, there is an occlusion or a blockage. So an MI occurs due to coronary artery occlusion. So it's blocked. There's insufficient blood supply, which causes ischemia, so reduced blood supply, which causes hypoxia, which causes infarction, which is why we have myocardial infarction. So it's only when sort of the condition is able to progress to this end, to this stage, to this sort of terminal badness as a result, that really, really permanent damage sort of occurs. So if we get to the heart or the heart attack patient sort of soon enough, we can stop it here and go back, and they should be relatively okay and certainly have a good survival rate. If you re-establish the blood supply, the myocardium is no longer ischemic, and so they can survive. Okey-dokey, so this is, here we go, left anterior descending, so LAD, occlusion, myocardial infarction. And this would be treated with a stent, I think, to open up the artery and just allow the blood to flow back through, restore tissue perfusion, so get rid of the ischemia, therefore get rid of the hypoxia because you're supplying oxygen, and therefore prevent infarction. And we talk about with heart attacks the golden hour, which any of you who have done a sort of paramedics or first responders course will probably be familiar with. The golden hour is you have 1 hour between sort of person suffering from a heart attack and you getting a stent in. It's like the golden window of opportunity to save them effectively, because myocardial infarction does not always equal death. Lots of people survive it, which is brilliant. Okay, and that is the end. We have run ever so slightly over. It's 6:10. Does anyone have any questions? As I've said here, you can put them in the chat, or you can unmute and ask them if you want. Asking me about specialities. So guys, you're sending me messages privately. That's cool. If you want to post them in like the common chat so everyone can see. The question that's been asked is, do I personally have a speciality that I'd like to go into? And this is an interesting story. So I applied to medical school 2 years ago now, with the intent of going into neurosurgery. I did some neurosurgical experience at Coventry and Warwickshire University Hospital to put on my personal statement before I applied, and it was fantastic, and I loved it, and it's really in-depth and detailed. But a lot of neurosurgical patients don't make it. It's a very dangerous pathology to have, a neuro pathology. Neurosurgery is high risk. And so now I'm swaying towards a specialty. I definitely still want to be a surgeon, but I'm swaying towards a specialty where the patients are more likely to, well, survive effectively. I'm not sure if I'm quite the right person to deal with that level of loss in my career. So I'm thinking probably MAXFAX, maxillofacial surgery, for anyone who doesn't know that abbreviation, which is to do with the bones of the face, because I'm still very interested in sort of the head and neck. I find it the interesting or most interesting part of anatomy. And the only other surgeons that really go up there are MAXFAX surgeons and neurosurgeons. So if I can't do neuro, I might have a look at MAXFAX. But thanks for asking me about that, taking an interest in my career. That's quite nice. Does anyone have any other questions, either about me or about the heart or anything we've covered today? Okay, I'm going to assume that's a no, although if anyone's frantically typing, carry on and I'll see it. But yeah, I have a question for you. So given this event, which I hope you enjoyed, and the last couple of events, someone has put something in the chat, are the slides available after the webinar? So this links in, the slides being available, the recordings being available, and also this question here, would you be interested in future events like this? We are working at Pre-Med Success on developing some sort of online platform whereby you'll be able to go back and view previous lectures and also download the slides and maybe even suggest new topics for us to discuss in future talks. So they are currently not available, but I definitely like to make them once we've got that online system set up, and I can send out sort of you're all subscribed to the mailing list, so you'll definitely all be aware when that sort of goes live. I'll let you know. I have a poll for this last question. There we go. So we can have a look. So would you guys be interested in any future events in the new year? Oh, thank you so much. Oh, that's lovely. Nice. Good to know that you've enjoyed it. Good to know that you've enjoyed it. Okay, I'm going to stop sharing that. There we go. In that case, I won't keep you any longer. Thank you so much for coming. Obviously, feel free to get in touch with me. My personal email is there. Then there's also the business email and our website. Feel free to get in touch if you have any questions about this, any of our previous talks, future talks, or even tutoring, as we are a tutoring service. Have a wonderful Christmas, and I hope to see many of you in the new year.